Welcome, everybody. We are very happy to have a dear colleague of mine, Benda, here. I'm going to be talking today about her work on recentering AI for mental health towards patients. With great computing power comes great responsibility. So very happy to have you here. Thank you so much. I'm going to read off her bio now, and then we'll get started. So, Matt, go. Yeah, so Dr. Benda is an assistant professor of health informatics at Columbia University School of Nursing. She is an expert in human factors engineering and human-centered design, where scientific approaches that investigate how people acquire, use, and interpret information. Human factors experts leverage this understanding to build tools that support cognitive work in high-risk environments such as healthcare. She holds a PhD in industrial and systems engineering from the University of Buffalo and completed her postdoctoral training at the Weill Cornell Medicine's Division of Health Informatics. Dr. Benda's program of research uses human-centered design to advance the inclusivity and equity of healthcare with a special focus on consumer information technology. Her work spanned across various clinical domains, including mental health applications for general, geriatric, and perinatal populations. Dr. Benda currently has an ROO award, from the National Institute of Minority Health and Health Disparities to design an mHealth tool to support Black and Spanish-speaking Latina women in reporting and managing somatic and psychological postpartum symptoms. Very, very important work. Okay, so we'll go ahead and get started. Very happy to have you here. Can't wait to hear about your work.
Great, and thank you so much for the invitation. I'm really happy to be speaking to all of you today. So today I want to talk a little bit about, not all of the applications I present will be mental health related, but I know digital mental health is a general focus of this group, and I will be focusing on some different ways that we are thinking about how do patients feel about the use of AI for mental health specifically, thinking about that in a general sense, and then also kind of this example that I'll talk a little bit more about throughout the talk is, what would a dashboard look like that presents risk to patients? And this one specifically is about postpartum depression. But before getting into that, I did just want to kind of give an overview of the current grants that I have, because I'm not going to be talking about all of them. So as you can see, I really do like to focus on kind of populations that we know are oftentimes, minoritized or disadvantaged, and think about how we can help use technology to better support people in their care. So this is the grant that Heather mentioned in the introduction, and I'm actually not going to be talking about that one as much today, because artificial intelligence, as many of you know, is characterized by not being particularly explainable. So oftentimes we have to do some reverse engineering to even find out what's, how the artificial intelligence works, what's driving artificial intelligence-based risk scores. And this is actually a grant where we're using a pretty simplified algorithm to give people advice about when they should seek care for concerning postpartum symptoms. But I just mention all of this in case there's work that I don't cover today that anyone would be interested in connecting about later, or I'm happy to kind of answer more questions about some of the other work I'm doing towards the end of the talk. If anyone does have questions throughout the talk, feel free to unmute, and I'll also do my best to keep an eye on the chat. So in general, I first just want to talk about my research approach. I anticipate, since you all will do digital health related topics, a lot of the terms I talk about will be familiar, but I just want to make sure that, we're all on the same page about what it means when we say things like human-centered design. And then I'll be talking about 3 different use cases as to how people I work with and myself, we have been thinking about human-centered design of artificial intelligence, and then specifically getting into some mental health related use cases. So first, I do just like to talk about, human-centered design. I anticipate a lot of people are familiar with this approach, but the way I usually like to think about it is that we have patients who may have differing and individual needs. And usually we're in this digital mental health space where we're trying to give people information to improve their health. And then we also have to be thinking about, who's giving them this information, and then what are the contexts under which people work with, and how can we be as inclusive as possible to people's different needs. And then I specifically think about how can we have human-centered solutions that are, inclusive, as I mentioned, with the ultimate goal of at least trying not to make health disparities worse, but really advance health equity and support groups that may sometimes be underrepresented or feel like their voice has not been heard when technologies are created for more of a general population. So first, thinking about usability, I'm sure this is an important construct in the work that you all do, but it's also quite important to artificial intelligence for, possibly obvious reasons, but, the main one being that if something isn't usable or perceived as useful, then people aren't going to use it. I know that we, in AI, we talk about, how far we've come and the promise of AI in healthcare. But this in particular report was a report that was published by RAND in about 2021. And then there was this systematic review of how different artificial intelligence tools had improved healthcare. And essentially what was found is that aside from image analysis, AI really has not been implemented across healthcare domains and been shown at a high level to improve health outcomes. So what people are really good at from the perspective of either predictive AI, where we're trying to predict an outcome, or generative AI, which I know we hear a lot about now with things like ChatGPT, is they're very good at simply predicting an event using large amounts of data. But in terms of actually then implementing that artificial intelligence in a way that's usable, that health professionals or patients could use it, we haven't come as far along. So there's a lot of papers that have shown that people can easily predict things, for example, like depression. But in terms of actually getting that information in front of mental health professionals to more proactively predict mental health conditions or, conditions in general, we haven't really gotten as far along in that regard. So that's kind of where the work that I do focuses. And this isn't a mental health example, but there was recently a paper that came out in JAMA Open where they had a score or an AI-based risk score that predicted thromboembolism and had an AUC of 0.9, which is quite high performance for those of you who aren't familiar with those metrics, though I anticipate many of you are. But they found out that it didn't really improve outcomes in a randomized controlled trial, even though that they were supposed to be able to more proactively predict who would have these thromboembolic events. What they found when they dug a little bit deeper is that even though this was a really highly accurate piece of technology, the recommendations were only taken about 25% of the time, or only adhered to 25% of the time by the health professionals that were supposed to be receiving them. So that's really kind of the area where I've focused my work on AI. Is we know that there are things for which AI can be predictive and helpful, but then what happens between having a very predictive model and actually getting it to the right person in the right context at the right place, the right time, and things of that nature. So the other thing that we also, or that I kind of in my work try and think about related to AI, is that we want things that are inclusive. And so accessible for and usable by. So when we talk about inclusive design, we want things that are accessible for and usable by as many persons as reasonably possible. What we may often hear about in AI is that we know that our health systems are systematically biased. And if we're using data that really comes from people who have made decisions, then those AI algorithms may also be biased to give care, for example, to more insured populations, things of that nature. So that's one thing that I think people hear about a lot when it comes to AI. So what I try and think about more is how do we limit something that's called intervention-generated inequity, such that interventions work better but for groups that are already advantaged in a health system. So there's people who do this more from a computational perspective, trying to understand how we can mitigate biases related to AI. But the way that I try and think about it is making sure that if there are biases in the AI, how do we convey that to the user so that they can make decisions appropriately or decide if those tools should really be used at all, thinking about it more from kind of the human-computer interface perspective. And then thinking about patients, making sure that we are getting feedback from diverse groups of patients and not just the patients that are the most positive about AI and are the most inclined to kind of use and trust technologies. So I started a project when I began my postdoc in 2018 This is the project that's not specifically mental health related, but it was about predicting high preventable utilization, which is kind of a complicated topic for people to wrap their heads around. Although oftentimes we have algorithms we know that are preventing readmission. So there was a quantitative arm of the study that I was involved with. It was funded by PCORI, where they were trying to predict patients with preventable readmission before they were readmitted to the hospital. But then we also kind of had this other arm of it to say, well, who's going to be using this information? When should it be presented to them? How are we going to implement this? And so the purpose of the qualitative arm that I was involved with was both to inform, for this particular study, what do we have to think about when implementing an algorithm like this? And then we also know that there are some strengths and challenges of predictive algorithms in general. What could a qualitative study talking to different stakeholders teach us about how we could and should be implementing AI? So we used a theoretical model from Siddig and Singh about the implementation of health information technology in complex adaptive environments. I mention this because this is also, although it was stemming from the initial implementation of electronic health records, in a lot of the work that I've done related to AI, I found it's very applicable in terms of the dimensions of the model in thinking about how can we implement various different kinds of technology. So we asked people in this qualitative study about, what their current activities were, perceived usefulness of an algorithm like the one that was being developed. Usually in the work that I would do, I would want to, first determine that the algorithm that's being developed is going to be useful either to patients or health professionals. I think a lot of times there's this push that just because we can predict an event or generate text or an image, we should. But I don't know that there's always as much consideration as to, is this really an important need that patients and health professionals have right now? So we did kind of ask people, theoretically, would this be an algorithm that's useful to them? How would it be implemented? And then kind of perceived barriers and facilitators to actually getting this algorithm in front of people to be able to be utilized. So we were able to recruit people from health systems, both in New York City and in Florida. And we interviewed people that were at operational, informatics, and end users. I'll show you first just like what all those roles were, because I think they could be a little bit vague otherwise. So the main purpose for which they wanted to implement this model was to identify people, as we mentioned, that we thought were at risk for high preventable utilization and get them enrolled in better preventative services, like making sure they had a primary care provider, getting them a community health worker or some type of health coach if needed, making sure they have the resources they need to get to their appointments. So we had this kind of large group of potential end users. We also wanted to talk to the people that would take a model that was derived primarily for research and then implement it in a real-time fashion such that people would see it when they were looking at the patient's chart. And then lastly, we also talked to a lot of different C-suite and operational personnel to understand if this is something that would be useful in their health system, particularly because at the end of the day, these are the kinds of people that are making the decision about whether or not the hospital is going to spend resources on implementing a predictive or generative model. So I want to go through not all of the results. I'll show you the citation for this paper at the end, but some of the ones that have been important kind of in the past almost 6 years that I've been doing this work in where the research directions have gone. So it was interesting that some of the socio-technical challenges were perceived as more challenging than the technical pieces. And this is, essentially to say that, it's not no effort to create these models from a computational perspective, but in general, we have the computing power and the resources to create these models and implement them real time with electronic health record data. The thing that was more challenging, and you can see in some of these quotes related to, people in communication, is that, it could be implemented fairly easily, but that part was not resource intensive. What people thought, was more challenging was thinking about who's getting the information and what are they doing about it. And that wasn't necessarily an easy question. And I think this is important in the work going forward, because that's kind of the place that we see as sticking point for a lot of AI at this point is it's predictive. We know that it works well for certain applications, but then who's getting that information and who's doing something about it? The other thing that was also important is that, in order for this information to be trusted, it really had to be actionable. And it was really important, unsurprising, that there was kind of an involvement between members of the care team. So in this case, that would be primary care providers, the end user, which would actually be like a nurse manager that the patient may not know well, and the patient themselves. And that feedback loop of who's informing the patient of their high risk, who's introducing the potential intervention, was really important to trust and uptake of the intervention. So for example, how this would have worked, it would typically be someone who's letting the patient know that they're eligible for these services. But if you can imagine, as a patient, you get a call from someone you've never spoken to before, and they say, we think you're at risk for being admitted to the emergency, or being admitted to the hospital, or going to the emergency department within the next year. That'd probably be a surprise to a lot of people. They would ask, how do you know that about me? How do you know this information? And, even though it may be a highly predictive model, and we know we may have some good interventions for that patient, that doesn't really facilitate trust in the loop as to how patients are told this information. So for this particular model, it was really important that the primary care provider kind of told the patient that they would have someone reaching out to them, and really trying to support that uptake piece of the intervention that was tied to the predictive model. And that's really something that kind of has become a thread in some of the other work that I'll be talking about. So in general, kind of what the other things that we found from this study is that it doesn't end necessarily in the predictive AI piece with just identification. What that means is that the person who's receiving information that a patient, for example, is at high risk, they want to know what to do. So it's actually kind of the same case in some of the postpartum depression risk prediction work that I've been involved in, is that usually it's the obstetrician who is alerted that the patient may be at high risk for a mental health issue. And while there is a little bit more training among obstetric health professionals about what to do for mental health, they may also not know what the best thing is to do for the patient from the mental health perspective. So not only do people want to know that a patient is at high risk, they wanted it to be really easy to then take action for that particular patient. It was also very important to the end users that there was some transparency so they could understand how the model was developed. What they meant by that was that they didn't necessarily need to know the mathematical inner workings of the machine learning algorithm, but they wanted to at least know what variables were used to create the model. And that would help kind of develop a sense of trust as to like a litmus test as a clinician to say, okay, I think I can, generally trust that that would make sense. And then it was also really important to not take the person out of the loop, and that really there was really someone involved through all of these different stages. So for example, people pointed out that, having clinicians and informatics professionals involved early on could help pinpoint data quality issues. So for example, if a data element was collected differently in one place as opposed to another, that could actually lead to performance differences at different clinics. And that would be something to point out early on. They also wanted to understand what's the value add of these particular models, because, for example, maybe they're being developed for a case that actually isn't that much better than clinician decision making, or maybe the model's picking up specific patients that the clinician would not have thought would be at high risk for these outcomes, and that piece they really wanted it to be transparent. And then the next piece that was really important was to consider if, how, and when the patients were involved. And this is really kind of the piece that I've been interested in and going to consider in some of the other work that we're doing. So especially for, thinking more than to a mental health perspective, thinking about how to be sensitive about, socially situated issues, and how can we make sure that this AI is not just patient adjacent. So obviously, yes, we want AI to improve health outcomes, But really, you know, in a lot of the work that I've seen, the patient is a bit more of an afterthought once the AI development has been done. And then it's someone who's being acted upon, being offered an intervention, as opposed to thinking about how can we have the use of AI be as patient-centered as possible, as opposed to the patient being kind of, you know, adjacent as someone who's not an active part of this process. So that's kind of how I've been thinking about this work from a mental health perspective. I will just note here that if you're kind of interested in this paper, although it's, you know, less on the digital mental health side, this is the publication that talks in a little bit more detail about the first kind of use case that really started the team that I work with in thinking about some of these problems related to AI and how do we think a little bit more about how the patient is involved. So then I did want to move on to mental health related use cases that I have. Before I do that, are there any questions or things that I can answer? Okay, good. Just wanted to give people the opportunity. So this is all.
I have a question.
Oh
Sorry,
yeah, go ahead.
I do have a question.
Sure.
So, you know, you were talking about going back to patients and, you know, saying, oh, you know, you're at high risk, and the patient going, what? Surely there's some kind of consent or buy-in or something for the patients whose data is being mined, and maybe it was buried in some consent form that they signed 6 months ago and they have no memory of it. But I'm just curious about, like, what is the consent or buy-in from patients initially?
So for the most part, actually, for the development of predictive algorithms, because there's so much data used to create the predictive algorithm, people usually get a waiver of conformed consent, which is another problem and something that we've been asking patients about in another study is at first just like, how do you feel about your data being used in this way? And then for you as an individual, would you want to have the opportunity to provide consent as to whether or not this clinical decision support algorithm, for example, should be used for you? So for this, you know, for a lot of these developmental studies where they're just creating the algorithm, they get a waiver of consent. So that's something else that, you know, the patient probably may not even be aware that their data is being used in this way, which is another kind of problem at the source here. So I'll talk a little bit more about this in a mental health related grant that we've been working on. So we have the PI has a parent grant that is an STTR from the National Institute of Mental Health, which is a small business based award. And our colleagues essentially have developed an EHR-based model for predicting postpartum depression during pregnancy. But then we had a supplement award that was added to this grant to think about what are some of these ethical considerations about using artificial intelligence in this way. What do patients think? And then what do other stakeholders think? And how can we implement these kinds of models if they are shown to be effective in identifying patients in a way that patients would potentially be comfortable with? So as I mentioned, this company is based in using machine learning to predict postpartum depression proactively. Since this is a mental health working group, I anticipate that many people are aware that depression following childbirth actually is higher than in the general population, and it can be sometimes challenging for people to identify at that point in time. And there's also, you know, a shortage of clinicians who are trained to support people in the perinatal period, you know, kind of during pregnancy and after pregnancy and childbirth. And oftentimes, you know, people may have pretty severe issues with depression that go undetected. So the goal of our colleagues was to first see if they could use retrospective data and create a machine learning based algorithm to accurately predict postpartum depression during pregnancy. I have one of the citations here, but they essentially created a pretty high performing model. It's also been analyzed to ensure that certain biases are mitigated and there's not essentially certain groups that are more likely to be recommended for care than others. So from our perspective, the human-centered design questions where we first wanted to know, you know, in general, how do patients feel about the use of AI to support their mental health care? And then we wanted to learn a little bit more about how patients felt about, this type of model or approach being used in their care. So, and then thinking about that, what are the best ways to show the information to the patients if it finds out that they are at high risk? So first, we wanted to do a survey just to understand how the general population feels about the use of AI for mental health care. So the reason we wanted to focus on patients, in addition to some of the previous work that we had done, is that most work on explainability and implementation of ML or machine learning in healthcare has really focused on clinicians. And from what we found in the literature, very little has focused on patients. Because of the 21st Century Cures Act, and I'll talk about that in a second in case not everyone's familiar, and some of the laws against information blocking, it's actually becoming more and more likely that patients see the results of predictive algorithms. So if people aren't familiar, there was an act about 2 years ago that wanted to get away from blocking information from patients and essentially making patients become the owners of their own data. So like things like open notes, if you've heard of that. And because of this, patients are more likely to essentially see risk scores in their patient chart if they have access to this information. So it's becoming more and more likely that patients may see some of the clinical decision support and other risk scores that are being calculated to support health professionals. So it seemed important to think a little bit more deeply about what happens if a patient sees that they're at high risk for something, maybe before they go and see their health professional. And, we've also kind of know that patients may have concerns about sharing data related to their mental health and how these types of algorithms are calculated. So our colleagues had previously completed a survey about asking people how they felt about the use of artificial intelligence in healthcare in general, but all of the issues that they looked at were only somatic issues. So things like having AI read a chest x-ray, having AI diagnose pneumonia, things of that nature. And they didn't include any perception questions related to mental health. So we thought that this was an important opportunity to ask some questions more about how patients felt about AI being used for their mental health care. And then we also have this kind of nice built-in comparison from the survey that our colleagues had did that's shown here. So what we did is we used an online survey platform called Prolific. We essentially just recruited adults that we were only able to do this particular survey in English, which I do realize is a limitation. And then we were able to balance our sample based on age, sex, and race to reflect the current demographic population of the United States. And what we did in the survey is we actually kind of just took all the questions from the previous survey and adapted them to focus on mental health as opposed to general health care. So people were asked about their general perspective, their concerns regarding the use of AI for mental health care, their comfort with AI to do various mental health related tasks. And then, since this was a grant about bioethics, we also asked patients how important different facets were related to, the autonomy with how their information was used, beneficence, justice, trust, privacy, and transparency. So we kind of just asked what their perspectives were and what was important to them in terms of the use of AI for their mental health. So this was our sample in general. We recruited a sample of exactly 500 people with a mean age of 56. Overall, we were not able to, we had a little bit lower sample than we would have wanted in terms of seeing kind of Hispanic patients participating. And we also wanted to get a kind of an idea of people's experience with mental health and mental health care. So we actually did have a relatively high number of people that had noted that they had kind of experience personally with mental health and mental illness. So the first thing that we asked about were different concerns related to the use of AI in their mental health care. So I'll first go through some general descriptives. I'll then talk about within our sample some differences we found based on sociodemographics. And then last, I'll talk about the comparison of this survey to the somatic health survey that had been conducted previously. So in general, we saw that people were most worried about was essentially, medical error relating from the use of AI, that they may have the wrong diagnosis, that it may lead to them getting inappropriate treatment. People were also pretty concerned about spending less time with their mental health professional and having their mental health provider not knowing them as well. And then people were overall not quite as concerned, but still had relatively high levels of concern about confidentiality and increasing costs. So even though these last two were the levels of the things about which they were least concerned, you still see that about almost 50% of people are somewhat or very concerned about these particular facets related to their mental health. We also, yeah, go ahead.
I'm just wondering about how much introduction people were given about the use of AI. Like, were there specific use case examples, or I guess a description of how it could be used? Because I think the possibilities are endless, right, with AI. So it could be used in so many different ways. I was thinking about that because of the first item here about diagnosis. Like, is that really what it was going to be used for? Or was more like risk scores towards potentially, informing that the person might need a diagnostic workup, rather than, a definitive diagnosis, of course.
So everyone was given a definition of AI and kind of an example of what it could be used for in healthcare, with a focus on predictive AI, because this was kind of before the big explosion of ChatGPT talking about generative AI. So everyone was given a definition. And then based on the other survey, we actually came up with specific tasks. And this is my next slide about what kinds of things would they be comfortable with AI doing to support their mental health care. And in general, the tasks were making a diagnosis. So just, do you have this condition? Do you not? Delivery of a diagnosis, which I think we could all agree isn't the best thing that we want AI to be doing, but it was in the previous survey. So we wanted to see. And we also looked at those tasks for what we considered a less severe and a more severe condition. So we asked about it for both depression and bipolar disorder. And then we also asked about AI recommending various different kinds of treatment related to mental health. So these were the different tasks that we asked about. As you can see, people were not at all comfortable with diagnosis delivery or making a diagnosis at all for the more severe example that we gave people, which is bipolar disorder. People were also not comfortable with recommending a medication, diagnosis delivery about clinical depression, and kind of most of these as you go down. The place where people seem to begin to be more comfortable was if the AI was recommending non-pharmacological intervention. So people were, about 50-50 on performing a mental health assessment. And then we're getting to see more like 60 to 70% of people being comfortable with AI recommending talk therapy or general wellness and management strategies. So we kind of just tried to see what people would be comfortable with, even though knowing that some of these may not be something that would really be helpful for AI to do from a mental health context, but we were just kind of trying to understand across a very broad spectrum, what would people be comfortable with? William, do you have a question?
Yeah, I was wondering if you had basically an equivalent plot for what mental health providers' views were.
So we do not. So we're starting this year to do more interviews with mental health providers, but we haven't been able to ask them these questions. So we also then asked people just about their values for AI related to mental health. The thing that was interesting is, as you can see, although some values are more important than others, about 80% or more of people said these were all at least somewhat important. So going along, these are all things that people generally viewed as important. The one thing that I thought was kind of most interesting is that people wanted to be able to understand their individual risk or the factors that were predicting their risk. And we use depression as an example for this one. The reason it's not probably surprising when you think about it, but when we think about the way that we're currently presenting predictive algorithms, it's not very frequent that we're actually telling people what's driving the AI's prediction. So I thought that was interesting, that seemed to be what people found was most important. And it's kind of an area that I think will be important for follow-up to understand, okay, so we're giving someone a risk score, how do we show them what's driving the risk score and what's a good way to help them be able to understand that? So I also then wanted to talk about some differences. We weren't able to do modeling for every single question to look at demographic differences for what people thought, or what was kind of, affecting people's opinions. But we did do, we created a logistic regression model for this one general question related to overall in the next 5 years. Do you think mental health care, do you think AI will make mental health care in the United States? And it was, the options were somewhat better, much better, somewhat worse, much worse, or don't, or you could say, they could say neutral as well. So it was almost exact 50-50 split between somewhat and much better. So 49.3% of people said they thought it would make it somewhat or much better. Interestingly, we then tried to look at the odds ratios to see if any of these sociodemographic variables were significantly predictive of thinking that this would make, that AI would make mental health care somewhat better or much better. So we saw here that in general, females had an odds ratio less than 1, meaning that they were significantly less likely to think that AI would make mental health care better. But then those identifying as a Black or African American race, or those having inadequate health literacy based on a validated health literacy screener, were actually more likely to think that AI could make healthcare somewhat better, somewhat or much better. So this was possibly surprising, just given what we know related to kind of trust in the healthcare system among racial minorities. It's something that we're really interested in continuing to explore, and also kind of wondering if there's an element of thinking that maybe a computer could be more fair than kind of human-based clinicians, and that was what was driving this result. But once again, this was from a single survey, and we kind of want to explore that more as to why we could have seen those differences. And it also seems really important kind of to explore people with inadequate health literacy, thinking that AI could make mental health, much or somewhat better, to make sure that people in that category really understand what it means for AI to be used in mental health, and that the information that we're presenting meets different health literacy related needs. So a couple of additional results. We also noted that people thought it was very important to know when AI plays a role in their mental health diagnosis, even if over 50% of people even wanted to know if it played a small role. A vast majority of people said that if the machine learning algorithm was accurate 80% of the time and disagreed with their mental health professional, it would make them question the mental health professional's assessment, which is, concerning to hear, but also important to know and think about in the future as to, is there a way that AI and mental health professionals can work more collaboratively, so the mental health professional has an opportunity to say, I don't think this is appropriate in your context for these reasons, for example. And then the other thing that was concerning as well is that they were asked, if the AI was wrong, who was at fault? And about 80% of people said that they thought that mental health professionals would be responsible for medical errors or wrong diagnoses. They were more divided on who had the responsibility for ensuring safety of machine learning based algorithms, but that was a really important finding, just so we can understand in the future, especially given what we know about, shortage in mental health professionals and burnout among mental health professionals, making sure that there's a better way to kind of be sharing the burden for what happens when these things are wrong, and trying to better, create a collaborative relationship between the patient in light of some of these AI-based tools that we may see more often. So the last thing that I wanted to talk about a little bit is the comparison to the somatic health survey. So we looked at, overall for somatic health versus mental health. In the other surveys, people in general seem to be more optimistic about the use of AI for a general health context as opposed to a mental health context. They were more comfortable receiving a diagnosis for a somatic health or a general healthcare application when the model was 90% accurate, but was not able to explain how it got the result. And then people felt in the mental health survey thought that it was more important that they were to be told when an AI had played a large role in their diagnosis or treatment. This is a less perfect comparison, but I did want to mention it. So we had deliberately developed the scenarios for the mental health survey based on the somatic health survey and classified them under assessment, diagnosis of a less severe disease, diagnosed delivery of a less severe disease, and then delivery of a more severe disease. So it's not perfect comparing, depression to pneumonia and bipolar disorder to cancer. And I want to acknowledge that. But in every case, except for the diagnosis delivery related to bipolar disorder and cancer, which people were just generally very uncomfortable with, people were more comfortable with the use of AI for the somatic disease related cases than they were for the mental health related cases. The last thing related to this survey that I wanted to show people is that we also had people give the ability to have free text answers to different questions. And they discuss different themes related to concerns about AI performance, human AI dynamics, and then just kind of additional concerns. I have picked some of kind of the starkest examples, but I really wanted to show that, it seemed like overall there was some optimism towards the use of AI for mental health, but the quantitative data didn't really convey the grave concerns that people had. So for example, you can see this one says it will be sexist, biased, and racist. It will rely on old ideas of mental health care and not use current information. It will be used to ignore or bully patients. And then other people had really extreme concerns about what would happen with overdiagnosis, or if the AI led to them being used, had extreme decisions, like what would it be used for? While, hopefully AI would not be used in a vacuum to do some of these things, people were concerned about it. And it seemed like there needs to be a lot more information to kind of help people understand for what AI would be used. And in general, kind of one of the main cross-cutting themes that's not surprising is that, if AI is going to be used, it needs to be used in collaboration with a trained mental health professional and not on its own. So in summary of this particular survey, we found that there were significant differences based on gender, race, and health literacy regarding optimism towards if AI could make mental health care better, and some of those in a direction that we found somewhat surprising. There was a lot of variability on the types of tasks people would be comfortable with AI accomplishing. Participants valued understanding the risk factors that were driving AI's decisions. And then for certain constructs, patients were more comfortable with AI use for somatic disease than mental health disease. And then as we just saw, some of those qualitative results revealed some really grave concerns, although there was some consensus that if AI are used to inform decisions, that it should be essentially supervised by a mental health professional. We do have one paper that did a sub-analysis of perspectives of female identifying people on the use of artificial intelligence for mental health care. That was published in a special issue, but we're still the results that I presented today are mostly still under review. So I have another example I can go through, but I do see that we only have, about 14 or 15 minutes left. And I wanted to open it up for questions about this particular survey or, some of the work that I presented thus far.
Ooh, I have another question. So really cool stuff. Here's my question. Long before ChatGPT ever existed, we talked about the value of actuarial versus clinical judgment, right? And this is not something that lay people understand anything about. And what we find over and over again when we do those studies, whether it's interpreting an MMPI or assigning a diagnosis, this is entirely within the mental health world, is that actuarial judgment gets it right way more often than clinical judgment does. AI is really just a way of formalizing actuarial judgment. So I understand why it makes lay people anxious, but I think lay people don't understand how unbelievably flawed human providers are and how subject we are to biases and halo effects and heuristics, and how often does the average mental health provider actually even do a structured diagnostic interview? Like the answer is like almost never, right?
Yep.
And so things get missed all the time. I mean, just take OCD. OCD gets missed like 90% of the time because nobody bothers to actually do the structured diagnostic interviewing to ask the right questions. So while I am very sympathetic to the concerns that patients and lay people have about this, and I take very seriously that we don't want to bake our existing biases into a model that's then just going to reify them. I also just want to throw out there that this notion that having humans cross-checking things, whether you're talking about reading mammograms or diagnosing mental health, humans kind of suck at this stuff. So I just want to put that out there and see what other people think.
Yeah, and I'll just add that actually in the paper that we just submitted, I've talked to one of my colleagues who does a lot of the machine learning development of this, and we talk about how AI is actually under a lot more scrutiny than human decision makers in a lot of these ways. And one thing that we had in the discussion point that I think we're really interested in is like this value add piece. So is there a way that, yes, people want to know how reliable these models are, but I think it would actually be really interesting to show this model, although 90% accuracy may not sound high enough to you, that's compared to a 60% accuracy of a human decision maker. But those kind of mathematical concepts can get complicated, but that's something I think we're really interested in showing, like, although this may not sound highly accurate and the, use of computers to do these things is scary, it actually improves decision making quite a bit and thinking about how we can do things like that. But I'd really be curious to hear, what other people think about that, or, if that would be possible.
Yeah, so I mean, just a quick thought in the ethics literature, that same issue has come up time and time and time again, not just in mental health, but generally. I would flag, though, that like it's quite easy for those of us who are in digital mental health to overpredict the accuracy of AI models on certain diagnoses. Like the accuracy of AI models for psychosis, suicidality, etc., ain't all that great. And so there's a feature of like the severity of the outcome that needs to be accounted for, I think, that are mucking with people's intuitions and judgments a bit too, right? You saw like bipolar disorder, don't want things mucking around with that. Now, there was a lot of noise, I think, about what was going on in some of that data, but yeah, it's there are a lot of models currently out there in use that are at least as bad as human judgment, and often when they're wrong, so profoundly wrong that it's concerning to even people who know a lot, I think.
Yes, absolutely.
Yeah, I think it comes down to, the trust of the model of the AI to get it right. And as you were talking, Will, I was thinking about some edge cases where, like, for example, anxiety within the autism spectrum looks very different from like general anxiety. And so how would a model, account for all of that? And hopefully they would have some, information about it. But for at least for that example, there's not a lot of clinicians that really know what to do in that case. So there wouldn't be a lot of information to be able to put into the model. That's an ongoing area of work. So I'm sure, for predicting or informing about, more bread and butter kind of mental health diagnosis like depression and general anxiety, but that might be a really good fit. But then when you're thinking about edge cases, like how does that all work? So yeah, I think it's interesting to see from this perspective, from the people who are going to be receiving, the services, what they think about it. But I hear what Will was saying before about providers. It would be good to see what they think as well. And we'll find out, in your next sort of work.
Yeah, I agree that like trust is really important. And obviously participants want to understand these risk factors. I'm curious about how well clinicians are explaining like the algorithms that go into it. I can imagine like a physician is not particularly well versed or trained in machine learning or anything like that. And if you want the participant to understand, I guess there's a gap there. Like, how can we get them to understand when machine learning already this complicated task that goes into it?
Yeah, and that's actually something that, and I probably don't have time to go through the whole thing, but that's something that we worked on a little bit in the subsequent study. This photo's a little bit grainy, but we essentially looked at 4 different ways to convey postpartum depression risk to patients. And we had a pretty simple use case where we just asked patients, is it recommended that you get treatment or not? And we found that there were not any significant differences in how they classified their risk based on performance, but that's also a pretty simple task. Like, are you below or above the threshold for looking at those different risks? The one thing that we did find that those results were a little bit muddy is that the text only condition, where they weren't given a % risk number, just said you're above or below the threshold, was the condition that led to the least trust in their health professional. So we did have a little bit of data to show that people do they want to know what that number is of how high their risk is. But I think the thing that we are really interested in next is, how do we explain machine learning or AI to patients in a way that gives them enough information to make an informed decision, but in a way that can be easily understood by diverse groups of patients with different educational backgrounds, et cetera. And that's where we're trying to take some of this work, not only in the postpartum depression space, thinking about, pregnant and perinatal people, but also, people who may be involved, like the care team, and, thinking about then how do technology developers think about this as well.
Yeah, that communication piece is really important, trying to, I'm sure in a lot of the work that you've been doing, I know you do a lot of participatory work, feeding back what you've learned to the community, conveying that in a way that is, understandable from different groups, different stakeholder groups. It's really tricky and really hard to get it right. And a lot of, iterative development kind of work needs to happen on that side of things, as well as the technology piece, right? So trying to get a very clear message is sometimes pretty challenging, but yeah, certainly a lot of input from the community can help with that. I know you know.
Yeah, and that's, I think, one of the things that we're trying to work on next. Do people have other questions, or I can talk a little bit more about where our future work is going, but I'm also happy to discuss. I think that's sometimes the most interesting piece of some of these talks.
I guess I have a pure speculation question, but feel free to just beg it off. What do you think is going to happen to your responses as you get the granularity more specific to how things might actually be implemented? Right. So you were commenting upon, I know how some of these things actually wouldn't be used clinically for these tools. And I'm wondering, what do you think is going to happen when you get patients and or other stakeholders who have no expertise to understand what actually might be the implications for using them in clinical practice?
Well, I think we saw it, that people were really felt like it was, like Rage Against the Machine. They really thought that this was pretty scary in terms of doing the kind of implementation, especially from the qualitative responses. But we are trying to get a little bit more concrete in how we show this information to patients. And for the most part, when we've been doing interviews with patients, they have said that they would typically want to be able to discuss this information with their physician or their provider, whomever that may be. So I think there's also kind of an AI literacy piece that I know many other people are working on for clinicians as well, but that's a little bit outside of my area of expertise. And so going forward, as I mentioned, what we're trying to think about is, what are some of the best practices for presenting AI to patients in terms of risk communication, in terms of, hopefully being able to show what variables are putting them at risk, although that involves kind of some complex math and reverse engineering in ways that, some of the kind of machine learning community has questioned if that's very accurate to reverse engineer these models. And then we're also trying to think a little bit about, do these concepts apply to when we're thinking about generative AI versus predictive AI? And how do we help kind of ensure safe, trustable use of AI when it's warranted in some of these cases? Because there's some pretty scary examples of people with mental health issues using generative AI, having kind of, nervous breakdowns, having it continue to promote delusions because the generative AI doesn't know that the patient's suffering from a mental health issue. and thinking about what could safe use look like with these types of technologies, if at all. All right. I will add my contact information there, and I'm happy to kind of talk about. So this is kind of what this is what we've been trying to like little by little evaluate in terms of what would a dashboard for patient-facing AI look like. But there's still kind of pieces of this that we're working through. So please feel free to reach out to me if you have further questions.
Well, thank you, Nat, for a wonderful talk. A lot of stimulating work that we're all sort of mulling over still, like I am. So yes, I want to thank you for that, and just for the rest of the group, just that you know what's happening next month. So we have Ian Barnett, who's coming, going to be talking to us about his work in directing the Penn unit for mobile app sensing. And thanks again, Eric, for facilitating that upcoming meeting. I'm sure Nat will be happy to answer any extra questions if anybody wants to reach out to her. Thank you again, Nat, and have a wonderful month, everybody. Eric, we'll see you next month. I probably will not be there, but I will be probably at the next meeting after that.
I'll handle it. Yes.
Thanks again, Nat.
Thanks for the invitation. Bye, everybody.
Bye. Thank you.